The topic of the latest medical workshop organized by the Armenian American Health Professionals Organization, AAHPO, at the St. Leon Church was protecting your eye health. As always, the event was free and open to the public. After the welcoming remarks on behalf of the St. Leon Church Parish Council, President of AAHPO, Dr. Larry Najarian, spoke about the purpose of the medical workshops and the larger mission of the Health Professionals Organization, which celebrates its 25th anniversary this year. AAHPO organizes a new medical workshop nearly every month in different churches and with different medical topics.
We've accomplished quite a lot, and we're in gratitude to the early board for keeping AAHPO alive. We've really branched out. We are officially a 501c3, 100% volunteer organization. All of our work, our medical missions, everything we do is volunteer-led. So we appreciate all the contributions of many, many people over the years and your support. This is our 25th anniversary, and do keep October 19th free. That's our anniversary banquet at the Palisadian, and we look forward to seeing you.
All participating panelists made brief presentations on the day's topic of eye health. First, Dr. Leonard Feiner, MD, PhD, ophthalmology, spoke about diabetic retinopathy and macular degeneration. Dr. Leonard Feiner graduated from Princeton University with a degree in mechanical and aerospace engineering. After deciding that medicine was his calling, he was awarded a grant from the National Institute of Health to support his studies at the University of Pennsylvania School of Medicine, where he received his MD and a PhD in neuroscience. He is a retina specialist with New Jersey Retina.
We're going to start by talking about diabetes. Diabetes mellitus. First diagnosed, understood to be a medical disease about 3,500 years ago in Egypt. They recognized that some people who were getting ill were drinking a lot of water, so they were very thirsty, and they were producing a lot of urine. And one of the things they noticed was that the urine they produced attracted ants. And the Greeks, about 1,500 years later, when they started tasting different body fluids, realized that the urine that was produced tasted sweet. And that's where the disease gets its name. Diabetes translates from Greek passing through, so meaning you urinate a lot, and mellitus means honey. So to pass through honey. Right now, the world, the global prevalence of the disease is about 285 million people, and it's expected to rise to about 439 million people as the world develops more. And the way diabetes causes all organ damage is that hyperglycemia, high sugars, damages that capillary bed and begins to close down those small blood vessels. And as you lose them, the organs don't get enough oxygen, they don't get enough nutrients, and they begin to fail. Diabetes primarily impacts the retinovascular circulation. When a patient's had diabetes for a while, the first thing we notice, the first finding that you can see is what we call non-proliferative diabetic retinopathy. Normally when we look into the back of the eye of a patient, like I said, we can see the arteries, the finer blood vessels, we can see the veins. We can't really see that very fine network of capillaries. They're too small to resolve. But in diabetes, when the wall of the capillary becomes damaged, it develops a little sidewall bulge that's called a microaneurysm. As patients have the disease for longer duration and don't take care of themselves, ultimately we begin to see more changes. We begin to see small hemorrhages in the retina, little bruises where blood cells extravasate into the interstitium between the cells of the retina. We begin to see fat deposits in the retina, and this is when patients begin losing vision. The later complications of diabetes are the development of abnormal new blood vessel growth in the back of the eye. Once the circulation really starts to fail, the body has reparative mechanisms. In any other spot in your body, these repairs would be good. You're developing new blood vessels to help nourish tissues that aren't getting enough delivery of oxygen and nutrients. But in the eye, these blood vessels grow into the central cavity of the eye. They begin to break and they bleed, and we'll see that in the next picture. But basically what happens in these patients ultimately is they come into the office completely unable to see because blood is blocking their area of central vision, or this is called a subhyaloid hemorrhage, this is a vitreous hemorrhage, but both of these cases, this patient is walking in really hand motion vision. They can't really see anything at all. So how do we deal with these different complications and fix them? The most important thing to do is to take really instill in the patients the importance of taking good care of their diabetes, particularly when the disease is in their early phase. In the mid-1970s, with the advent of lasers, that was really the first treatment that allowed us to help patients with diabetes. And we still use laser to this day. We don't use it so much for swelling, which what's being shown in these set of pictures, but we do still use it quite extensively in patients who have that bleeding complication into the central cavity of the eye. In these cases, we do a laser treatment and we give time, and you can see this is a patient who presented with a vitreous hemorrhage, legally blind, and 2-3 months later, a year later at this point in this scan, the hemorrhage is gone and they're not going to bleed again because of the laser that's been done. Very effective treatment. In 2006, basically, we went through a real revolution in the care of patients with different retinal diseases. A company named Genentech came up with a drug. The first one was called Avastin, that works very specifically to help mitigate some of the proteins that actually cause the problem. And so they developed a drug that had basically no side effects that you could inject into an eye and would reverse the complications, both of diabetes and in wet macular degeneration. This is a doctor down in Miami. His name is Phil Rosenfeld. He was one of the first doctors to inject the medicines in the country. Here he's injecting a patient who has macular degeneration. And so we generally divide macular degeneration into two types. What people call dry macular degeneration and what we call wet macular degeneration. And the naming system is actually, in my opinion, terrible, but we're kind of stuck with it. 95% of people have dry macular degeneration, and typically, dry macular degeneration doesn't cause too much difficulty with a person's vision. Maybe they need a little bit more light to see than they used to. Maybe they notice a little bit of distortion when they look at a straight line doesn't look perfectly straight. But overall, they can function well. They have good detail vision. In patients who have wet macular degeneration, what happens is you have more wholesale destruction of the architecture of the retina and a real drop in vision. So this is not the best picture, but we're looking into the back of a patient's eye again, optic nerve, and you can see these little yellow spots in the back of the eye. So 100 years ago, when the eye doctors invented, the Swiss and German eye doctors invented the indirect ophthalmoscope and the slit lamp microscope, which are the instruments we use to look in. They were descriptive people. They saw little things sparkling back at them, and it reminded them of a rock with crystals on the inside, a geode, okay? The German word for geode is a druse. So they called them drusen, plural of druse. We still call them the same thing. And they're the byproducts, adducts of vitamin A. They should be cleared and disappear, but for some reason, in some people, they accumulate as you get older.
The panel continued with a presentation by Dr. John Aljan, MD, Ophthalmology. He focused on eye examination. Dr. John Aljan is a fellowship-trained, board-certified ophthalmologist specializing in cataract, new technology, intraocular lens surgery, cornea transplantation, severe eye trauma surgery, and laser surgery. He is a chief of the Eye Trauma Service of the New York Eye and Ear Infirmary. He has recently been nominated as Surgeon Director at the New York Eye and Ear Infirmary of Mount Sinai.
When should I have my eyes examined? Now that you're worried about this, you're thinking, maybe I should have my eyes examined. Actually, a newborn, right away, the pediatricians do a cursory eye exam just with a pen light or a strong light to make sure the pupils are reactive, there's no scars on the cornea, no congenital cataract that the baby could be born with. When you take someone's picture and they get the red eye in the picture, or you see a deer in the headlights with the red pupils, that's the red reflex. That's light bouncing against the retina, and that's a healthy sign to see in a baby, a red reflex, that there's nothing obstructing from the front of the eye to the back of the eye. If the baby is premature, then the baby needs a comprehensive examination, a dilated examination with an ophthalmologist, because there's a disease called retinopathy of prematurity that's blinding that we can treat if we diagnose it in a premature baby. And then an infant between 6 months and 1 year. I get this question all the time: why is Stevie Wonder blind? And can I do anything to help him? Stevie Wonder is blind because he was born 6 months premature. He was put in an incubator with a high amount of oxygen, and he developed retinopathy of prematurity. He had bleeding inside his eyes, his retina detached, And that's why he's blind. Wow. So again, we want to examine a preschooler. As soon as the child can read an eye chart, it's a good idea for an eye exam. And at this point, we could find out if the child is developing a lazy eye, if the child is nearsighted, farsighted, or may have astigmatism. And by the time school age comes, myopia or nearsightedness is common. I started wearing glasses in the 5th grade. And actually, that's what got me interested in ophthalmology. And the first thing we're going to check is your vision, okay? We're going to check your vision without glasses. Not that we care that much what your vision has without glasses. We really care what's your best corrected vision. How much can we improve your vision? Okay? This is the old eye chart. You've seen it 1,000 times. It's called a Snellen chart. We'll test one eye at a time and see how far down on the eye chart you can read. What does 20/20 mean? Everybody wants to know, right? So the top number, 20, denotes your distance from the eye chart. You're 20 feet away from the eye chart, okay, usually. And the bottom number denotes the smallest letter that you can read on the eye chart, right? So if the smallest line you can read is 20/40, someone with 20/20 vision, 20/20 vision is better than 20/40 vision, right? Let's say 20/20 is perfect vision. So if someone has 20/40 vision, okay, that person with 20/20 vision could see from 40 feet away, which you have to move up to 20 feet to see. Okay, so that's what these numbers mean. If you have 2100 vision, a person with 20/20 vision can see what you can see from 100 feet away. Refraction. This is what people get a bill for in my office and they get upset about because it's never covered by insurance, but it's very, very important. So the refraction is the process that determines if you're nearsighted, farsighted, have astigmatism, or you're presbyopic. This is a phoropter. Someone had the great idea to put all those lenses inside this device, so we don't have to have them loose like that. And then the person is on the other side, and the doctor is basically shifting through different lenses. You've been through this, what's better, 1 or 2, and we're checking to see if you're nearsighted, farsighted, and how much astigmatism you have and where your astigmatism is, basically. So that's the phoropter. All that phoropter is all those lenses in this device. Pupils. Observing how your pupils react to light can yield information regarding the visual and nervous system. We can tell a lot with a pen light. Just with a pen light and seeing how your pupils react, we can see if you have optic nerve damage, if you're alive or dead. There's a lot we can tell by just examining the pupils with a pen light. Motility. There are 6 muscles around each eye, 12 muscles in total, okay? They all work together so that you can look at something and move your eyes together and fuse, okay? And if any of these muscles are weak or damaged, you can get a misalignment and you can get double vision, diplopia. That's a motility exam. Tonometry. Elevated eye pressure may be a sign of glaucoma. Gonioscopy. Doctor's looking through a slit lamp. He has this little lens that he's looking through the microscope, through that lens. The lens has mirrors. He's looking into the front part of the eye, and he's looking into the drainage tract inside the eye. Fluid is made in your eye, and fluid drains out of your eye in a balance. If more fluid is made that can get out, the pressure in the eye starts to rise and damages the optic nerve. Slit lamp examination. Dr. Feiner mentioned the slit lamp. The slit lamp microscope is like the stethoscope for the ophthalmologist. It's a precision instrument that provides the examiner with a highly magnified view and a 3-dimensional view of the eye. Tear glands. Your tear gland makes tear to bathe and nourish your cornea. It could atrophy, it can be inflamed, it can get infected, you can get cancer in it, it could not do its job, you can get dry eye, and then the tear drains, where your tears drain. You can also have a problem with that. Here's your tearing system. There's a gland underneath your eyelid, okay, temporally here by your temple, and that elaborates tear that nourishes the cornea and cleans the front part of your eye. And there are 2 holes, one in your lower lid, one in your upper lid. The tears enter the puncta, then these canaliculus, into the side of your nose, and then into your nose. That's why when we cry, sometimes our nose runs. Cataract, most commonly due to aging. You can be born with a cataract. Children, babies can have cataracts. Smoking, eye trauma, previous eye surgery, prolonged sunlight exposure, increased risk. Diabetes, topical or systemic steroids can increase the risk of cataract. This is how we remove a cataract. A very 2.4 millimeter tiny incision is made through the cornea. We open the front part of the cataract. It's almost like plastic. There's a lens capsule around it. We open this plastic. Using ultrasound, we sculpt out very carefully that cloudy protein from the lens capsule. And this is very, very delicate surgery. The cataract is suspended in the center of the pupil by these fine little zonule fibers, these fine little fibers. And that lens implant will never degrade, never age, never go bad. It's going to last the rest of his life. And it's amazing technology. And these lens implants keep getting better and better. This plastic lens implant is not going to get cloudy. That little sac that's holding the lens implant, that can get cloudy. And he may need to go and have a laser, make a little opening in that capsule to let more light into the eye. But the lens implant is going to last 5,000 years. And as time progresses, these lens implants are getting technically more and more advanced.
Then Dr. Lawrence Najarian, MD, Ophthalmology, touched upon the leading causes of vision loss. AAHPO President Lawrence Najarian, MD, is the founder and medical director of the Bedminster Eye and Laser Center in Bedminster, New Jersey. A board-certified ophthalmologist, he is a graduate of the Johns Hopkins University, University of Pennsylvania Medical School, and completed his residency in ophthalmology at New York University Bellevue Medical Center. He received special training at Moorfields Eye Hospital in London and Emory University.
In a large room of 100 people, I am sure somebody has glaucoma and does not know it. So this is why you need to go for your preventative exams, particularly if, again, if you have a mother, father, brother, sister that's lost their vision. And again, this is what a normal nerve looks like. And when we look into the back of the eye, this is a diseased nerve. Do you see the difference? Here we have a lot of healthy, pink, robust tissue and a very small white spot. And as the nerve dies, the normal, healthy pink tissue goes away. And it looks like somebody actually took a bite out of the optic nerve. This shows what happens in glaucoma. In the beginning, you can see everything, there's no problem, but gradually your field of vision is lost. The last thing to go is your central vision. Here we see a patient with diabetes. We've heard diabetes is a preventable cause for vision loss. Macular degeneration is different than glaucoma. In glaucoma, we said you can't see peripherally. In macular degeneration, you can't see centrally. In fact, with somebody with severe vision loss, when they look at you, they don't look at you, they look to the side. They're using their peripheral vision. And this shows the macula is a very, very tiny area. The macula is equivalent to a tennis ball on a tennis court. So if you destroy this very, very small area right over here, you will lose your ability to see fine things. Your peripheral vision is good, but your central vision is not. This goes to show what's called a macular hole. And this person, they won't be able to see the eye chart very well, but they'll still be able to navigate and walk around. With cataracts, they're very, very common, and they can, particularly in the older population, are a very, very significant risk factor for tripping and falling. Tripping and falling is really a hazard. If you trip and fall, your risk of developing serious disease and dying is very, very high. But this is an example of thyroid disease affecting the eye. This shows what happens in thyroid disease. The muscles get really thick, and that's why the eyes bulge out. This is a patient who went from my office to the emergency room and admitted to the intensive care unit. This is an example of severe, uncontrolled high blood pressure. So this patient presented to the ophthalmologist first with loss of vision. So when you come in to see us, you might just think you need glasses, but when we approach you, we're thinking about all these other diseases that are going on.
The last panelist, Dr. Kunadi Kachadurian-Meyer, PhD, RDN Nutrition, epidemiologist, spoke about nutrition for the eye. AAHPO board member Kunadi Kachadurian-Meyer, PhD, holds an MS and PhD degrees in nutrition, epidemiology, and public health from Columbia University. She holds teaching positions at City University of New York, New York University, and Columbia University. She is a founder and president of the Bergen Nutrition and Weight Center.
Healthy eating combats aging and disease. And what's healthy eating? It's healthy eating is how much you eat and what you're going to eat. That's a decision you have to make. And it should be based on knowledge. it should be based on knowing what is a balanced diet or something close to it, so you can make the right selections. The first thing you need is protein for growth and cell repair. The other one is fats, fatty acids for nerve protection and to produce satiety. Carbohydrates to provide energy for functioning of the various organs, the heart, the brain, and regulate the brain's serotonin. Many people have thrown the carbohydrates down the chute. Oh, I don't eat carbohydrate. Why? Oh, I'm on a diet. Well, that's not the way to diet. You still have to include some carbohydrates in your plan, because otherwise your brain will complain and your organs will complain. Okay, the other group are vitamins and minerals, but that's only adding to the group that I just mentioned. The vitamins provide healthy enzymes to help in metabolism and the Krebs cycle, which is your furnace. It helps you work the furnace better.
By the end of the workshop, the panelists gave detailed answers to all the questions from the audiences.
So I think it's very important what they're doing. They're donating their time and their generosity, and they're helping our people. Who knows what will come of some of the people they've helped that will benefit the Armenians all over the world.
Very good, excellent. Anybody who didn't come missed it. Next time when they come, make sure to come and listen. You get good advice.
Today's lecture was very good. I think it was very eye-opening and very informative. I hope there are more of these types of sessions coming soon.
The evening was very informative and very helpful, very comprehensive, and in simple language so that we could understand. All of the speakers, they were just wonderful, and I'm very happy that my husband and I came to hear and learn.
I'm so happy that I was able to come and listen to the doctors speaking. They were absolutely wonderful, and we got lots of new information that will be making us feel better. Thank you so much. I appreciated their coming and giving all their time to us. It was a late night for them. They put in a lot of hours, and they're going off to work tomorrow, and I'm not.